Bismillah ar-Rahman ar-Rahim. Good evening, everybody. I would like to, before kicking off, I would like to thank you all for your, for your valuable presence and sharing me the discussion of this common and important topic in endocrinology, which is polycystic ovary syndrome. Which might be in fact encountered by any one of you as general physicians. So it might be quite important to be updated regarding the common concepts of treatment according to the international guidelines. So for the purpose of this presentation, I've relied on the guidelines of the American Endocrine Society as well as those of the Androgen Excess and PCOS Society. So for this presentation, I'm going to discuss a typical case scenario, then I will talk about some of the definitions and diagnostic criteria, then I will talk about some of the clinical manifestations before concluding with the treatment options and wrapping up. So my case is a 26-year-old girl who presented with hirsutism of 3 years duration with weight gain and irregular menses, which satisfied the definition of oligomenorrhea. The physical examination showed a mildly obese girl with high blood pressure and few acne on the forehead, thin hair, acanthosis nigricans on the neck. She scored 12 in the modified Ferriman-Goldway score, and pelvic and general examination didn't reveal an evidence of an underlying condition apart from the suspected diagnosis. The basic workup showed blood glucose in the pre-diabetes range, hypertriglyceridemia, normal thyroid function and gonadotrophins, elevated testosterone, free androgen index and prolactin. As you can see that the LH and FSH didn't exhibit the classical raised ratio, which would be supportive to the diagnosis and would be reflected to the trophic effect of hyperinsulinemia on LH in particular. However, we could make the diagnosis based on Rotterdam criteria and exclusion of the other differentials as we are going to discuss. So PCOS might be having a heterogeneous and complex etiology which is centered around the metabolic and reproductive consequences of hyperinsulinemia, which might be out of the context of this presentation. From a diagnosis point of view, there are 3 definitions which are currently in use. The NIH and the Rotterdam, as well as Androgen Excess and PCOS Society. All of them have utilized 3 main features: the hyperandrogenemia, the oligo or anovulation, and polycystic ovary morphology in the ultrasound, which has been first introduced by the Rotterdam criteria. The clinical hyperandrogenemia might be reflected clinically in the form of hirsutism, androgenic alopecia or acne, or biochemical. The oligo or anovulation might be reflected as oligomenorrhea when the intermenstrual periods or interval are more than 35 days, or even polymenorrhea when they are only less than 21 days. And ovarian polymorphic polycystic morphology by the ultrasound, which has been first introduced by the Rotterdam criteria and mandates the presence of at least 12 follicles of 2 to 5 millimeter in diameter in each ovary, and more recently and more sensitively having an ovarian volume of at least more than 10 ml, which might be having a specificity up to 100%. So NIH mandates the presence of both hyperandrogenemia and oligo or anovulation. Rotterdam requires satisfaction of 2 out of those 3 criteria. Therefore, universal screening of every patient regarding the hyperandrogenemia and ultrasound morphology might not be indicated as long as the patient has satisfied 2 out of 3 criteria. And that for androgen excess and PCOS criteria, it mandates the presence of hyperandrogenemia in association with any one of the other 2. So in the absence of an evidence-based criteria, it might be valid to use any one of them in our clinical practice, and in fact, it might be even a healthy practice to utilize them in the research according to the population and the power of the study that you are intending to pursue. All of these three definitions are consistent in considering the diagnosis to be a diagnosis of exclusion. Therefore, we need to exclude certain conditions, including hypothyroidism, hyperprolactinemia, which by itself might lead to overproduction of DHEA sulfate at the level of the adrenals and forming multicystic ovary, which might confuse the picture. The other way around also, PCOS by itself also might be associated with mild to moderate hyperprolactinemia, which might or thought to be related to relative hyperestrogenemia. Non-classical congenital adrenal hyperplasia is considered to be the great mimicker of PCOS and needs to be excluded, especially that many of our patients might be having infertility issues and family planning is part of their main concerns. Cushing syndrome also is very important to be ruled out, especially with the predominance of metabolic features. The other differentials which might be needed to be ruled out, especially in certain clinical contexts, are pregnancy, hypothalamic amenorrhea, premature ovarian insufficiency, and androgen secreting tumors, especially with the predominance of hypervirilization symptoms. That applies to the diagnosis in full adult female. The diagnosis in adolescents might be a bit more tricky, as the anovulatory cycles might be part of the normal pubertal development, and them by themselves might be associated with higher serum androgen and LH level. So oligomenorrhea might not be pointing to the diagnosis unless they are quite persistent 2 years beyond menarche. In addition, hirsutism by itself might develop slowly because of shorter period of exposure to androgens. Androgenic alopecia might be not helpful because they are not studied well in this category of patients. There is a lack of standardization in androgen assays. The Rotterdam criteria by itself has not been validated in this category of patients due to the interference of multifollicular ovary, which also might be considered as part of normal development, in addition to the sensitivity of the transvaginal approach in this patient. So some authors have suggested to have an elevated anti-mullerian hormone level to be an indirect clue for the diagnosis in this category of patients, although we do lack clear cutoffs in this patient. So the diagnosis should depend on the presence of clinical and biochemical evidence of hyperandrogenemia in the presence of family history and persistent oligomenorrhea. The diagnosis in perimenopausal women also might be even more complicated because of similar lack of standardization in the androgen assays. Also, the presence of PCOS morphology might be less likely due to the aging process, although this tends to be less intensified in this category of patients, which might be considered as an indirect clue for the diagnosis. As well as the age-related decline in androgens might be less intensified in this category of patients also, which might suggest the diagnosis. Additionally, the metabolic consequences of PCOS might be persistent up to this age, so they might be used to suggest the diagnosis retrospectively. So the diagnosis should depend on a well-documented long-term history of oligomenorrhea and hyperandrogenism during reproductive years. These three main features might be having a variable correlation to the diagnosis due to the fact that everyone has its own strength and limitations. So we need to consider these limitations before utilizing them in making the diagnosis. PCOS might be having a wide spectrum of clinical manifestations which range from symptoms, association, and complications. I'm sure that many of you are aware of the cutaneous manifestations, which might be a reflection of hyperandrogenemia like hirsutism, acne, and alopecia, and acanthosis nigricans and skin tags, which might reflect hyperinsulinemia. Now, the presence of certain morphologic features or certain phenotypes might be having different risk and comorbidity profiles. Therefore, proper history should be conducted in order to have better reflection of the associated comorbidities. Therefore, we need to know more in the history about the age of onset, rate of progression, the response to treatment, and or any change with the fluctuation in body weight, family history, as there is a strong genetic component in PCOS. Therefore, good family history and screening of the first degree relatives is indicated. In addition to the features of hypervirilization, which might reveal an underlying tumor and severe insulin resistant states. Hirsutism, as we all know, that it is the presence of terminal pigmented hair in male pattern, is highly associated with this condition. And in fact, it is mainly related to with those who with abdominal obesity. Therefore, its correlation mainly associated with the metabolic consequences. It might not really fully predict the ovulatory dysfunction. There are several tools to evaluate for this problem. One of them, which has been suggested by the Endocrine Society, is the modified Ferriman-Galway score, which quantitate the intensity of hirsutism throughout 4 grades in 9 androgen-dependent areas. The upper lip, the chin, the chest, upper and lower abdomen, the thighs, the arms, the upper and lower back. In spite of having its own limitations, like ignoring the hair in some important areas like sideburns, it is still considered to be one of the best tools to evaluate the patient, especially at the time of diagnosis or later on in follow-up to monitor the response to treatment. Acne and alopecia might not be as strongly associated with the diagnosis. In fact, they might not be as good markers for hyperandrogenemia as compared to hirsutism. Androgenic alopecia by itself might be more associated with the metabolic complication. Therefore, it's very important to rule out other underlying conditions. Also, similarly, there are several tools to evaluate for androgenic alopecia. One of them, which has been suggested by the Endocrine Society, is the Ludwig score, which classifies the severity into mild androgenic alopecia, in which there is the hair fall is scanty with the preservation of the anterior hairline, moderate alopecia with more intensive hair loss extending laterally away from the center, and severe androgenic alopecia, which is quite, or severe, which is the hair loss is quite severe, so it is visible to the naked eyes. Obesity also is another metabolic association. In fact, it has been shown to occur at rates similar to the obesity and cluster in PCOS families. Its impact within the PCOS context, it might related to the hyperandrogenemia by itself. Also, it might be related to the, or it is more related to the metabolic consequences, as well as ovulation and menstrual abnormalities, especially when the weight gain occurs at the time of puberty rather than infancy. Also, it might be used to as a prediction to the response of the patient to treatment, especially fertility treatment. Therefore, BMI calculation and measurement of waist circumference is indicated at the time of diagnosis and later on in follow-up, especially for those who waist circumference is indicated for normal weight PCOS. Diabetes type 2 also is another major metabolic complications, as PCOS patients have been shown to have 5 to 10 times higher risk to develop this problem. And in a major study among US patients, the overall prevalence of impaired glucose tolerance was 35% as compared to 15% among the non-obese, while those who developed diabetes were 10% as compared to only 2% among the non-obese subgroup, which might reflect the augmenting effect or influence of obesity in causation of diabetes within the context of PCOS. PCOS patients also have higher prevalence of having a first-degree relative with diabetes. Therefore, again, a proper family history, screening of first-degree relatives for diabetes is very important. As part of their natural history or the natural history of diabetes in PCOS patients, we expect progressive deterioration. Therefore, oral glucose tolerance test is indicated at the time of diagnosis and later on at regular intervals, which have been suggested to be arbitrarily by the Endocrine Society to be around every 3 to 5 years or even shorter with the development of new risk factors. If the patient is unwilling to perform OGTT, hemoglobin A1C might be an alternative, although it might be less sensitive to the onset of insulin or glucose intolerance. Non-alcoholic fatty liver disease and non-alcoholic steatohepatitis also are other important metabolic complications which might be worth to be screened for by requesting transaminases, and liver biopsy might be justified at one stage. Obstructive sleep apnea also is another major metabolic complications which have been shown to occur at rates equal or exceed those in men. In fact, PCOS patients have been shown to have 30 times more likely to develop this problem and 9 times more likely to have daytime sleepiness. Obstructive sleep apnea have been shown to occur as a function of hyperandrogenemia and obesity. The good news is that the risk of development of this problem tends to be less with the regular use of OCPs, which is the hormonal treatment, and as well as CPAP. In fact, with more lengthy use of CPAP, this has been associated with less insulin resistance and even better diastolic blood pressure. Also, increased cardiovascular risk is tend to be augmented in our patients according to plenty of evidences in the literature, and also due to the fact that many aspects of this impairment tend to be reversed by several modalities of treatment like insulin sensitizer, and weight loss. Therefore, the Androgen Excess and PCOS Society have suggested a risk stratification system which classifies the patient as either having to be at risk or at high risk by having these features. Therefore, we need to consider all of these factors at diagnosis and later on. An important reproductive complications is the infertility, which might be primary or secondary and mainly due to anovulation, although other mechanisms might be implicated, like those related to oocyte maturation and endometrial receptivity. So therefore, a proper menstrual history has to be taken, and for those who are eomenoric PCOS, mid-luteal progesterone also might be requested. We need also to consider other causes of infertility, like obstructive causes, obesity-related causes, or sometimes male factors. The good news is that you are, as a general physician, might be still able to reassure the patient regarding their fertility potentials, as the monthly spontaneous ovulation rate has been found to be as high as 32%. And in a major study, 75% of women could conceive spontaneously. In another study also, lifetime fecundity has been found to be quite similar to the controls. And in fact, all of these fertility potentials tend to be more augmented with age in relation to the progressive decline of the androgens and more regularization of the menses. The pregnancy complications are numerous, which we need to consider, as well as the fetal implications, which might be quite interesting and quite exciting, especially with the concept of fetal programming, which has been extrapolated from non-human and human models. The endometrial cancer also is another, with its precursor, in fact, of endometrial hyperplasia, also is a major reproductive complication of PCOS with a relative risk of 3.5. Some of the epidemiological links have been shown to be the status of nulliparous, infertility, hirsutism, longer and longer period of oligomenorrhea, metabolic complications, as well as low physical activity as an add-on risk. Depression also is very common, and it is worth to be screened for with its complications of eating disorders, panic attack, and even attempted suicide. So the physical examination includes screening or searching for the dermatological manifestations of hyperandrogenemia and hyperinsulinemia, the features of hypervirilization, as well as to exclude the other differentials. Lab workup should include, in addition to the basic workup, fasting blood sugar and OGTT, lipid profile, which might reveal metabolic syndrome, LFT, gonadotrophins, total testosterone, and SHBG to calculate for the free androgen index, DHEA sulfate, and androstenedione, which might be, in fact, the only elevated androgens in 20% of PCOS patients. In addition, of course, to the prolactin and the other workup related to the differentials, which might include 17-hydroxyprogesterone within the context of short synactine test and dexamethasone suppression test to rule out Cushing. So the treatment, as we all know, that PCOS might not be a life-threatening condition, and many of its critical complications might be ameliorated by proper lifestyle modifications and weight loss. Therefore, the treatment should be tailored according to the patient's concern. If the main concern is the hirsutism, this might be approached directly or by hormonal therapy in the form of oral contraceptive pills, especially if it is associated with menstrual irregularities and failure of the mechanical methods. OCPs usually is delivered by the normal potency pills, which are 30 to 35 microgram ethinyl estradiol, which have been shown to suppress the LH and increase the SHBG, leading to lower level of free androgens, in addition to its anti-androgenic effect and inhibition of the 5-alpha reductase. According to the Endocrine Society, they suggest to be used for 6 months to have their effect, and for 9 months to have the maximal effect. For those who are intolerant or at risk, low-dose pills might be quite effective. The mode of action mainly is by disruption of the mid-cycle LH, but surprisingly enough, they have been shown to be quite effective in regularization of the menses as well as improvement of the other symptoms. The monitoring is mainly by androgens and FSH and LH levels. As we all know that OCPs are well associated with venous thromboembolism phenomena, which tends to be more exaggerated with those containing antiandrogens or steroidal antiandrogens, like cyproterone acetate in Diane and drospirenone in Yasmin, although they might be having the most anti-androgenic effects. The other agents or OCPs might be having other progestins like desogestrel, in, for example, and let us say Marvelon, and also gestodine also in Genera, and also levonorgestrel in microgynon. They might be more safe regarding the venous thromboembolism phenomena, but they might be less anti-androgenic. So we need to consider these factors, as well as the other considerations like age, smoking, obesity, hypertension, dyslipidemia, depression, unexplained vaginal bleeding, as well as diabetes with their more refining conditions. We need to consider all of these factors before prescribing or before picking up an agent or an OCP brand. Another line of treatment is the anti-androgens, which might be an option, especially upon failure of 6 months monotherapy with hormonal treatment, or when the patient desires a more intensified response. as they have been shown to be as effective as birth control pills. We have 3 anti-androgens in the market: spironolactone or aldactone, flutamide, and finasteride. The most popular one is the spironolactone, which exhibit dose-dependent competitive inhibition of androgen receptors and inhibition of 5-alpha reductase activity. It has some mineralocorticoids effect, so potassium level needs to be checked after initiation of the treatment, and we need to consider its teratogenicity. Therefore, it is advised to be prescribed with OCPs. Flutamide is less popular due to its liver toxicity, and finasteride might be less potent. Another option is eflornithine, which might be delivered topically as a facial cream to be applied twice a day for 8 weeks. It has been shown to be quite helpful in some situations, and it has been FDA approved. Weight loss and exercise have been shown to have the most favorable risk-benefit analysis, as they can restore the normal glucose tolerance, improve hyperandrogenemia and menstrual cyclicity with as minimum as 5 to 10% weight loss. Therefore, it might be wise to advise the patient regarding the calorie-restricted diets and to have at least 30 minutes per day of moderate to vigorous exercise in order to have the metabolic advantages. However, we need to consider the fact that this option might not be quite helpful or sufficient, especially for those PCOS who are normal in weight. Metformin also is another helpful option, which has been shown to attenuate hyperandrogenemia, improve cyclicity and ovulation rate, but it might not be as helpful in hirsutism. It shouldn't be prescribed by for everyone. According to the Endocrine Society and PCOS Society, only for those with impaired glucose tolerance or those who are unresponsive to hormonal treatment regarding the menstrual irregularities, or to prevent ovarian hyperstimulation syndrome within the context of IVF. Statins, if they are prescribed for hyperlipidemia, might be having another additive effect regarding suppression of the ovarian testosterone and androstenedione, but we need to consider their teratogenicity and other side effects. GnRH agonist, in order to induce ovarian suppression, should be your last reserve due to its long list of complications. It should be kept for those with problematic or unresponsive to hormonal treatment, or those with other conditions which might be treated by GnRH, like endometriosis. The treatment in adolescents might not be quite different than in full adults. In fact, hormonal treatment might be prescribed for even for premenarchal girls, especially when they exhibit more advanced pubertal development. The duration is not really determined. We don't need to stress on the lifestyle modification in this category of patients. And the metformin might be also an option, especially in the presence of metabolic complications. So, in conclusion, PCOS has a complex and heterogeneous etiology. The diagnosis is usually of exclusion based on several criteria, but we need to be cautious regarding certain age group. And the treatment usually is multidirectional, but we need to consider the genetic component of it. Thank you very much.